Hello, everyone. My name is Adrienne Burney. I'm the Outreach Coordinator for the State Archives, and I'm really happy today to welcome you to our virtual program, Where Did All the Midwives Go? Before I get started with introducing our speaker today, I'm just going to tell you a little bit about the State Archives and give folks a chance to join. Having a few technical difficulties with my screen, but hopefully everyone can see these slides okay. The State Archives was founded in 1903 with the creation of the North Carolina Historical Commission, and our collections are vast. We have over 100 million records, and that includes state and local government records, as well as private collections. And we have a variety of materials beyond paper, including sound recordings and photographs and other sorts of audiovisual materials. This image is of our headquarters in downtown Raleigh. We're right in between the Legislative Building and the Governor's Mansion on Jones Street. But we also invite you to visit us to do research at the Outer Banks History Center in Manio and the Western Regional Archives in Asheville. And all three of those locations are open mostly 5 days a week. Currently, our Asheville location is by appointment only. But you can also visit us anytime online. We have a huge digital collection, as big as our analog collection is. It's a small portion, but we're adding more all the time. A lot of our photograph collection is on Flickr. We have over 100,000 images uploaded on Flickr now. We do have some original primary sources on YouTube, but that's also our channel for posting recordings of programs like this. And then our blog and our podcast are ways that we can have further discussions about certain records or groups of records. So those are great places to search too if you're interested in a specific type of thing. All right, I'm going to introduce Genesis, but I also want to invite you all to post comments, questions in the chat or Q&A as she's presenting, and I will try to monitor those and let her know so she can have a conversation with you all at the end. All right, we welcome Genesis Wanapur today. She's a senior at Yale University, majoring in the history of science, medicine, and public health. And today's presentation is part of her senior thesis. She's worked with the Peabody Museum at Yale and also in the military collections here at the State Archives of North Carolina, where she was an intern this past summer. But she's not just a history nerd, and we love history nerds at the State Archives. She's also won several awards as the moot court captain at Yale, and 2 summers ago, she studied Korean in an immersive program. Holly Springs, North Carolina is her hometown, and we appreciate her contributions to the history of her home state and her willingness to share some of those with us today. So welcome back, Genesis, and thank you. I'm going to stop sharing my screen, which I should have done. Sorry, Genesis. I'm having trouble seeing this. There we go.
Thank you, and I appreciate it. I'm going to share my presentation in a second, theoretically. Okay, that should be visible now.
Yes, that looks good.
Perfect. Yeah, so hi everyone. As Adrienne mentioned, my name is Genesis, and I'm a senior at Yale studying the history of science, medicine, and public health. And last summer I had the great opportunity of interning at the State Archives, which was lovely and really helpful as I started to kind of work specifically with historical research to complete my senior thesis, which is titled, Where Did All the Midwives Go? Statistical Authority and Government Regulation of Midwifery During the 20th Century. So just kind of to get us situated at this current time point in history, if any of you have had a child or have been born, really in effect, you know that kind of today most births occur in hospitals, and we're kind of starting to see a reversal of that, where now some people are intentionally choosing and actively seeking out home births instead of hospital births, but that's a relatively new phenomenon. So I have some graphs here. The one on the left is from the Center for Disease Control, which just kind of shows the difference in out-of-hospital, home, and birthing center births. which if you kind of look at the axis of the graph, you see that the highest level is 1.6%. So these are still really a fraction of the total births that are occurring in the United States as a whole. And the graph on the right is specifically North Carolina data. So this is just for the past kind of couple or decade or the past decade or so. The blue line represents births that occur in hospitals, and the orange line is births that occur at home, whether intentionally or not. So you see there in the vast difference that really the vast majority of births that occur today are happening in hospitals. And in looking at kind of the vital statistics where this data comes from, there's a really large mechanism for the state, both the state government in North Carolina and the federal government more broadly, to kind of collect this data and to determine where births are happening. And we can kind of tell what the government thinks is important by the kinds of data that they're looking at. And that's something that's kind of broadly important in terms of my thesis. But in terms of birthing attendance, it's relatively a new phenomenon. The way the data looks right now is the state cares about whether or not a birth occurs in hospital or at home or other. There's a category for other. But just a couple of years ago, those weren't the categories. The categories were hospital versus not in hospital. So that's kind of a distinction. And then if you go a little back before that, the distinction is doctor in hospital, doctor not in hospital. So that's what the state kind of thinks are the big categories with which to be concerned. But then if you jump back to kind of the 1980s, the 1970s or so, what the state is looking at is doctor in hospital, doctor not in hospital, or certified nurse midwife. So we see there that the state is acknowledging that there are populations that use these care workers enough to an extent where the state would want to actually keep track of that. And if you go back before that, then they add permitted midwife as a section. And if you go back a little bit before that, the only distinction they make is between doctor and midwife, which recognizes that for pretty much the entirety of history, midwives played a very essential and a very large role in mediating births. And so keeping track of children that were born to midwives was very important. But if you look at the data today, the state has kind of acknowledged that midwives make up such a fractional population of births that keeping track of them kind of by name doesn't really make sense anymore. And so if we go back to 1973, this is a page from the North Carolina State Center for Health Statistics, which keeps track of all these vital statistics. And it's kind of hard to see, but if you look kind of under live births, you see there that under number 4, attendant, they're keeping track of physician in hospital, physician not in hospital, midwife, and other. So back in 1973, midwives were still a section kind of being tracked on these vital statistic lists. And 1973 is an important year specifically because it's the year where Beatrice Mongeau, who was a sociologist at the University of North Carolina, writes The Granny Midwives, Study of a Folk Institution in the Process of Social Disintegration. So this is one of the most comprehensive pieces of work we have about the midwives of North Carolina who existed before these regulatory movements came into play. So these are some of the last lay midwives, as they're often referred to. And Mongeau kind of conducts interviews with a lot of these women who are in their 70s, in their 80s. And this is kind of the last information we have about these midwives who existed kind of before our current system took place. So looking in 1973, these women, some of them are still actively practicing. And so it's important that the state is kind of keeping track of them. But we see just kind of 10 or 20 years later, these women have died or are completely retired, and the state is no longer tracking them. And what that means is essentially the regulatory movements that have been at force throughout the 20th century have been finally successful. So the bulk of my thesis kind of starts in the early 20th century, examining what those regulatory movements are that eventually resulted in the kind of compilation of statistics we see right when Mongeau was doing her work in 73. So this is kind of the thesis statement of my paper. What I'm looking at specifically is how a focus on vital statistics and specifically the infant mortality rate was kind of highlighted as an area of interest for progressive or social reformers, especially public health officials and physicians. And by looking at those statistics and kind of reading them, in some cases without context, midwives were kind of highlighted as an area of concern. There's an issue we'll talk about later called the midwife problem. And so doctors, separate from the fact that midwives were kind of professional competition for them because they were trying to serve the same populations of people, were explicitly looking to midwives as kind of a source of harm or a source of danger to women in North Carolina. And so what I'm examining is specifically a theoretical framework called authoritative knowledge, which is essentially where kind of one system of knowing, or science in this case, so specifically physicians and their system, kind of gained dominance over midwifery, which for most of human history had been kind of the way things were done. And I'm examining how vital statistics kind of played a role in that and eventually resulted in essentially the disappearance of lay midwifery from North Carolina. So we start kind of in the middle in 1920, which is when the General Assembly passes one of the kind of most important midwife laws that was on the books at this point. And so what they do is they pass a registration requirement, which essentially means that all midwives across the state, in order to continue practicing, have to register. This is different than a permit system, which comes a little later, in the sense that it doesn't actually kind of interact with the way midwives practice. It just is kind of a way for the state to get an idea of who's practicing and where, which on its face is, a very kind of above board thing for the state to do, but we'll see the ways in which it actually resulted, or the ways it manifested in regards with its interactions with midwife practice and how that affected what they were actually doing. But there are actually a couple of laws that happened prior to the 1920 law that are kind of recapitulated in this image that I've included here, which is from the state library. So you see that 6750 says midwives to register, which is the actual 1920 law. What they reference there, though, is an earlier law from 1917. You can kind of see that at the bottom of the paragraph, that was specifically about the inflammation of eyes of the newborn. So we'll see that that was an issue that was kind of spurring this law. If you look below, you see that there's a 1911 law also, which kind of forbid anyone who habitually got drunk from practicing midwifery, which is actually kind of the first midwifery law that North Carolina has on its books. And it's interesting because it's not really clear how they would have determined whether or not, or how, if someone was someone who habitually got drunk, or you can also see it talks about the use of morphine or cocaine. Not exactly clear how they were determining that, but that was a law that was on the books at this time. And then it was followed by the law on infant blindness, which I'll talk about in a little bit. And it finally coalesced in 1920 with this law about registration. And there are three things that are kind of affecting this law in general that are kind of spurring the General Assembly to get it on the books. So the first thing is something I mentioned a little earlier called the midwife problem. And this kind of starts to take root in the early or mid 19th century. So as you can see here, I've included just two examples, but there are actually so many of them, articles that were written around this time. You can see that the first one here was written in 1912 and the second one was written in 1928, but both before and after this, people are talking incessantly about the midwife problem. And essentially what the midwife problem is, I've included an excerpt from the lower article here, which was written by the director of the Division of Child Hygiene in Georgia. So he specifically says that the issue with midwives is partly that they are mostly compromised of Black women. So an important kind of contextual piece of information to include: at this point, most of the midwives who are practicing in America are either Black women or immigrant women from Europe. And as you can imagine, those are both populations during the late 19th century, early 20th century, who tend to be kind of on the margins of society, or don't have as much power, or kind of regarded by the system as being kind of inept. And that really occurs again and again in discussions of the midwife problem. Explicitly, it's this idea that midwives in and of themselves are dangerous to pregnant women, and that midwives are systematically untrained, they're incompetent, they're incapable of being trained. So it's not even that they don't have access to education, it's that even if you gave them that access, it wouldn't do anything. And that the source of the infant mortality rate or the maternal mortality rate is the midwife. So that's cropping up a lot in discussions of public health issues. It's cropping up a lot. If I go back to the last page, you can see that the first article was written by a nurse and the second article was written by a doctor. So it's kind of having full acceptance across the spectrum in terms of public health. This will be an issue later on, because we see when the state and the federal government kind of have the onus, or gain the onus in the progressive era, to kind of target issues of infant mortality and child welfare, it's already been highlighted for them that the source of some of those issues is the midwife problem. And so that's why this kind of crops up in the registration law. It's in part kind of a reaction to this idea that midwives are a source of danger. But one of the other issues that's happening, as I hinted at, is something called ophthalmia neonatorum, which is essentially infant blindness. So up until kind of the mid or early 19th century, this was one of the leading causes of blindness for children. And it was discovered around 1818 or so that one of the ways that you could target infant blindness was with silver nitrate, which was a solution that you would drop into newborns' eyes to prevent blindness. And so part of the issue was a lot of these midwives worked in rural areas. So specifically in North Carolina, they were working in rural areas, especially in the eastern half of the state. And so they didn't necessarily have access to silver nitrate in order to use it as a prophylactic. And so something the state recognized was that if you know where the midwives are by requiring them to register, then you can get them silver nitrate, and then you can help prevent infant blindness, which of course is cropping up a lot in these communities who don't have access to silver nitrate or who don't even know that it's necessary as a prophylactic. So you can see here in this top image that the state is specifically appropriating $3,000. This is in 1919 dollars to the prevention of blindness specifically. And so part of that is going towards equipping midwives with silver nitrate. And so the registration law was also partly in recognition of the fact that by registering midwives, you could understand who needed to get these medical supplies. You see there in the second image, that's also from the 18th biennial report of the State Board of Health for 1919, where they're also saying that kind of blindness is something that can be controlled if you educate parents on what it is, and if you control the activities of midwives. So an important thing to keep in mind with all of these regulation efforts is that they're not necessarily happening de novo or kind of separate from all this context. They're really happening with a focus for many public health officials towards eventually eliminating the midwife entirely. So these registration requirements are partly in recognition, and especially the permitting requirements, as we'll see later, are partly in recognition of the fact that it doesn't make sense. It's not logistically feasible to just kind of excise all the midwives overnight, because a lot of these women are working in rural communities who don't have access to doctors or hospitals. And so if the midwives were to disappear one day, there would be no one else to deliver those children. And so what they think is, if we institute these kind of changes gradually, so registration and then eventually the permitting system, eventually we can just shrink the population of midwives smaller and smaller and smaller until eventually no more midwives exist. And so that's kind of the focus of these regulatory requirements that are slowly kind of coalescing in this era. And so the third thing kind of affecting the registration law is this growing idea of vital statistics. So to step backwards a little bit, in the early kind of 20th century, so kind of around 1900, progressivism as a political idea is really rising. And part of that is this idea that the state and the federal government are responsible for child welfare. So it's kind of out of this idea that the Children's Bureau, which was initially part of the Department of Labor, but then grew into its own department in the early 20th century, that they form and they start looking specifically to the issue of infant mortality. At this time, infant mortality it's particularly high, especially for Black children or Native American children at this time period. And part of the Children's Bureau's job is to go into these communities and to figure out what is happening and why it's happening. And a large mechanism through which they do that is through the use of vital statistics. So also at the same time, kind of concurrently, there are vital statistics laws being passed throughout the country, which essentially require that public health officials, physicians, midwives, or undertakers, as you can see in the image, it kind of requires that these people provide information to state, local, and federal governments about who's being born and who's dying. And so there's this idea, as you can kind of see in the image, that vital statistics are essential for the government to kind of protect the public health, that the only way the government can kind of understand the public health and understand the issues that are affecting the public health is if they have statistics to back that up. And so there's this kind of broader idea of statistical objectivity, that if you just have these kind of plain numbers, these numbers will point you objectively and kind of without issue to whatever kind of public health issue is arising. But as we'll see as we get later on, that's not necessarily how you look at statistics. You know, today we're very cautious of how correlation is not causation, but in this time there's this idea that statistics are objective and factual, and if you just trust statistics, they'll lead you to whatever the issue was. And so in North Carolina in 1913, the Bureau of Vital Statistics is established. And so they are given the power to require that midwives, undertakers, physicians, all these people who are interacting with births and with deaths, that they send information to the Bureau so that they can keep track of this information. And as soon as the Bureau is formed in 1913, they actually approached the State Board of Health asking for a registration system for midwives and a permitting system for midwives. So the actual registration system doesn't happen until 1920. But in 1913, the Bureau of Vital Statistics is asking for it because they understand that midwives who are handling so many births, especially in rural areas where the Bureau's agents can't go, that if the midwives are registered and permitted, and if those things, if keeping that permit to practice is contingent on sending vital information to the Bureau, then the Bureau and the midwives are kind of locked in this professional coexistence, where for the midwives to keep practicing, they have to send the Bureau the information it needs to continue doing what it's doing. And that proposal was rejected by the Board of Health in 1913. They say it would be too difficult to get it through the General Assembly. We're just going to leave it alone. But the Bureau was still kind of allied to this goal of registration and of using midwives as a mechanism for vital statistics up until 1920, when the General Assembly finally passes the registration law. So these kind of three things, the midwife problem, infant blindness, and vital statistics, and the infant mortality rate, and the growing focus on those things as a means for solving public health issues, those things are all kind of wrapped up in the formation of the 1920 registration law. And so Article 9, which is where the registration law was manifested, kind of results in a new system of government supervision for midwives. The Shepard-Towner Act was passed in 1922 or so, and it essentially provided federal funding for state governments to do programs like this. So specifically to enact programs that were targeted towards maternal and infant health. And so using that federal funding, what North Carolina does is launch a county campaign of public health initiatives. And that's helped in part by county public health nurses. So these are women, usually white women, as you can see in the photo, who are trained as nurses and then who work for the state government and are sent to different areas of the state to, in some ways, to act as kind of purveyors of statistics or solicitors of statistics. They conduct actual physical examinations of midwives to see whether or not they're free from disease. They provide silver nitrate, and they look at children, and they keep track of midwives who are registered and midwives who are not registered. So in this way, the county nurses are really being used as kind of another vehicle of supervision, where they're directly going into these communities. And in some ways, they and the midwives are aligned, and they share very similar interests and similar responsibilities. But the nurses kind of exist in this hierarchy where midwives are at the bottom and physicians and the State Board of Health and other public health institutions are at the top. And so nurses in that way are kind of mediating the interactions between these public health institutions and the midwives in this work. And so you can see here from this picture, which is from the Dr. George Marion Cooper photography collection at the State Archives. This is a county nurse who's conducting physical examinations of children in a schoolroom in about 1920 or 1922. And so this was something that they would do, and then they would report all this information back to the State Board of Health, who would then, in their state reports from every 2 years or so, would publish the information that the nurses collected. This is the number of midwives who are registered. This is the number of physical examinations of midwives we've conducted. This is the amount of infant blindness that exists in these counties. So the registration system, again, is acting as this kind of way to entangle the midwives with the government, and these nurses are acting as a way to kind of enforce that power. So another thing that starts happening post-1920 is direct county control of midwives. So the nurses are funded by the federal government, mediated by the state government, and are working in county governments. But the county itself is also empowered to kind of enact educational requirements for midwives in the wake of the registration law. And so what that means is that individual counties kind of start to set up education requirements for midwives. So which is objectively a good thing, where they were teaching these women, here are signs you need to look for, here are times where you might need to involve a doctor in a birth, here are prophylaxis that you can use to protect the health of both the mother and the infant. But in some cases, this is a newspaper clipping from Robeson County, where E.R. Hardin was the health officer, and he is particularly important because he wrote an article at around this time or slightly after his county health education system had been implemented, specifically kind of admitting in a way that the point of the education system was not actually to educate midwives, it was to get rid of them. And so as Hardin saw it, what would happen is these women would keep coming to these educational meetings as they were required to. And from there, it would be easier to determine what midwives were qualified to keep practicing and which midwives were not qualified. So if a midwife missed her meeting, that would be an issue with the county department. If the midwife came and she didn't perform up to standard at the educational meeting, that would be a problem. And Hardin admits in this article that the goal is to kind of just reduce the population of midwives gradually and gradually and gradually until eventually there are no more midwives. And he says the reason for that is, one, these women can't actually be educated. He uses very intense language, which actually a lot of people who write about the midwife problem do. They kind of ritualistically refer to them as ignorant, incompetent, and untrained. And so rather than training them up to the standard that he desires, what Hardin says is eventually what this will do is it will create such a small population of midwives that they will be virtually extinct. And he acknowledges that in a perfect world for him, midwives would disappear overnight. It wouldn't be necessary to have midwives. All of the women in this case who were using midwives would just become obstetrical patients and would have physicians or nurses if necessary. But he also acknowledges that that is not logistically feasible, that there are just so many women spread so far across the state that really the only thing to do is to just gradually shrink the population of midwives. So these educational kind of meetings, while maybe on the surface being a very positive thing and being an opportunity for midwives to gain experience and to kind of benefit from the scientific developments and discoveries that were happening at this time, or actually, at least in the case of Hardin, but also for a lot of his contemporaries, the actual purpose of them was not really to benefit the midwives. It was just another mechanism of kind of shrinking the population of these care workers. So the next kind of aspect of government control or regulation of midwives comes again from the Bureau of Vital Statistics. So as I mentioned before, in 1913, the Bureau was created, and essentially they relied on birth certificates and death certificates to compile information about infant and maternal and just kind of morality in general. But if you look at the birth certificates that were being collected, and if you kind of analyze what they're saying about midwifery, you see again that it's not necessarily that this data is being used entirely objectively. It's being used to kind of prove a point, but it has this veneer of like pure scientific authority that is allowing the Bureau to kind of keep doing what it's doing in this case. And so this is an image of a standard certificate of death from 1929. So this was for a child, you can see if you look on the left half of the page, who died at about 3 months old. And so this was the certificate of death that a midwife or a physician would have been required to send in. But if you look at the cause of death, it says no physician, further information unobtainable. And that's kind of a very common thing for certificates of death for children who had been attended by midwives. A note about the infant mortality rate, which I've discussed, it specifically includes children who die under a year of age. So this child who died at 3 months would have been included in that number. And you can see here that the physician is kind of preemptively exempted from blame. There's no information obtainable, and it seems to impute kind of that there was someone other than the physician who was at fault, that the reason that the child died was that there was no physician, and there's no follow-up to that. There's no question of, was it kind of a sickness that occurred? Was it an accident? The reason is that there's no physician. And that kind of accords with other documents we're seeing at this time where and the absence of a physician in and of itself is seen as kind of a sufficient thing to say for cause of death. And that is always kind of implicitly linked to the presence of a midwife. They kind of tend to go hand in hand, where if a physician is absent, the implication is that a midwife is present. That occurs in a a document that came out from the Children's Bureau called Rural Children in Selected Areas of North Carolina, which was this kind of statistical survey of the state, where we see again this what I call presence-absence dichotomy, where a physician's absence implies a midwife's presence, and then all the blame that kind of accompanies the absence of a physician then falls to the midwife. So if we compare this one to a stillbirth certificate from a little later, from 1952, one of the important things to note about this certificate, which comes a while later, is that it now requires that if the birth attendant was a midwife, that she receive the authorization of a physician. So if you look in box 24, you can see there that it says signature of authorized official. And the person who signs off there would have been an MD. But even despite that, the cause of death, if you look to boxes 20A and 20B, is unknown. And so again, there's this kind of thing where the midwife is present and the cause of death is unknown. But even despite the fact that there would have had to have been a doctor at some point in the process to have signed off on the certificate, that blame or that kind of obscurity about what caused the death is being assigned to the midwife, right? In this sense of unknown, despite the fact that now a physician is present. And so in kind of looking at these, we see the way that these statistics, while they kind of seem purely objective when you're reading them from a report, if you go and you look at the sources of these statistics, there are these kind of implicit acknowledgments or implicit assignments, rather, of kind of who's at fault that are affecting the way that the state regards the problem, which at this time period is necessarily that midwives are the cause of the problem. So that is all happening under the registration system, which is instituted in 1920. But in 1935, the General Assembly comes back to the issue of midwives, and they institute a permitting system, which is necessarily more expansive than the registration system. Under the permitting system, now midwives are authorized to practice under the approval of the State Board of Health, and that approval can be taken away at any time for any reason. And the State Board of Health will just inform midwives, you are no longer authorized to practice. And that is a complete 180 from the way it's been in North Carolina and across the country for the last several hundred years. So before 1935, midwifery, specifically Black midwifery in the South, had kind of been balanced on two things, traditional practices and kinship succession. So traditional practices, as they sound, are just kind of lessons or techniques that had been passed down from midwife to midwife. So there are a few kind of common ones we see occur again and again in the South, which had been inherited from the antebellum period and had kind of been preserved throughout time. So one of those is passing an axe under the bed, which midwives would do to literally cut the pain. There was another one where they would sit a woman on a pot of burning feathers, and that was thought to help kind of extract or cause the placenta to be removed. There was one where after giving birth, a woman would walk counterclockwise around her house, and that kind of had different meanings for different midwives. There was one where they would literally tie the woman's legs with wire, and that was thought to kind of prevent bleeding. So there were lots of different practices that are being passed down from midwife to midwife. And in 1935, the State Board of Health says, absolutely not. If you get caught practicing these methods, that is cause to revoke your license. And that had been a very fundamental part of midwifery and for patients, because it's important to note that these midwives, as I'll get into with kinship succession, were kind of very much attached to the community. So it was very common that you would be born under the supervision of one midwife, and that midwife would then deliver your children when you got older. And so now these people are seeing these kind of practices that have been inherent to their community kind of just disappear overnight because the midwives are no longer allowed to practice them. And the other aspect of Black midwifery, which was very important and changed by the regulatory system, was kinship succession. So in that system, midwives would choose their own successor. So it was traditionally another female relative, or it could be a woman who felt she had been called by God. Divine calling was a very important part of this process, and you couldn't just wake up one day and decide to be a midwife, which actually becomes a problem later with the kind of new midwives that arise under the State Board of Health. And these midwives who've been raised under the system very strongly believed that it wasn't something you decided you were going to do. It was something that was decided for you by God. And so when you got that calling, or when you felt that it was your time, you would go to an older midwife in the community, and she would take you under her wing, and you would gradually kind of progress and get more and more patients and have more and more responsibility. And eventually, when the first midwife had decided she was done or that she was going to retire, you would completely subsume her practice. And it would be kind of this circular pattern for generations, where there would just be like generations of midwives all coming from kind of the same traceable line of succession. And the State Board of Health kind of puts an end to that. So you can see in this picture, this is from 1930, so a little before this registration law went into effect statewide, but this would have been a county kind of wide initiative. These are from Person County. And they've taken, as you can see, a course of instruction by the county health department, sponsored by a county nurse, and they're called a creditable looking group. And they are putting into effect the practical idea of improving the status of all midwives as long as there remains a single woman needing their services. And so pictures like this from this era kind of look entirely like this. It's all women who are dressed in very like clean, sterile white gowns. They look very reminiscent of nurses, because the State Board of Health is really trying to kind of erase the idea or the history of lay midwifery and kind of subsume that, if anything, into the county nurse system if they can't get rid of midwives at all. And so under this new permit system, traditional practices kind of go by the wayside. If we go back to Mongo, the sociologist from UNC, she is conducting interviews with women who were alive and practicing in 1935 when these laws went into effect, 40 years later in 1973. And so, and these women tell her that, you know, there were times where they attempted, or some midwives would attempt to kind of continue using their traditional practices. And if you were caught, that could mean you would lose your license. And that is especially important for kinship succession, because that's how new midwives would enter the system. So if you, as a midwife, you know, had kind of run afoul of the state board, and eventually they said, okay, we're taking your license, normally you would be like, okay, maybe I'm done, maybe I'm retired, but it's fine because I've already chosen and trained my successor. And sometimes midwives would just send their successor to the state board to receive permitting, and sometimes the state board would refuse to license them. So what that then is, now this woman who in some cases has had decades of experience already being trained, apprenticing under an older midwife, would just not have the permit necessary to actually practice. And it was also the case on the reverse side, where the county department would give permits to some women who it thought were good to be midwives, women who kind of weren't exposed to the old system, or who were willing to kind of work in accordance with the county's directives. And they would have the permits they needed to practice, but they wouldn't have the patients, because the patients would literally refuse to come to them. Or midwives, older midwives in the county, because older midwives kind of automatically qualified for permits under the 1935 law, would refuse to train them. Or they would tell the state board, oh yes, you know, send her over, permit her, and I'll take her under my wing, also her patients, and then she just never would. And in some ways, that was how they resisted this system of permitting. They would work in accordance with it kind of on the surface, but where it actually mattered in terms of treating patients, they would still use traditional practices, and they would refuse to work with the new midwives, or they would try their hardest to get the midwives they had chosen as their successors permitted so they could keep practicing. But eventually, the State Board of Health kind of wins out. And these women who are older, who Mongo was interviewing, who are in their 80s and 90s, eventually they say that they just kind of stopped sending their daughters or their granddaughters into midwifery because there was no future in it. At this point, the county has been somewhat successful in getting new midwives into the system and getting them trained. And these new midwives are much more likely to send their patients to the hospital. So at this point, the hospital system kind of works where if you're wealthy enough, you can choose to go to a hospital. And if you're incredibly, if you're kind of like the lowest rungs of the socioeconomic ladder, then you can also go to a hospital. There's provision for you. But if you're kind of in the middle, it's a little more difficult. And now these midwives, where if they had been trained under the old system, would have been much more hesitant to send their patients to a hospital, that would have kind of been viewed as something you only did if something was seriously wrong. Now they're much more willing to kind of send patients to a hospital, where now today we view birth as something that occurs in a hospital. that kind of idea, that initiative to send people to the hospital immediately is taking place with these new midwives. And so gradually, from 1973 kind of onwards, all of these older lay midwives are retiring or dying off, and no one who's trained under the old system is taking their place. Instead, it's the midwives that have been chosen by the county. And so if you think back to Hardin and his goal to kind of educate them to death in a way, it's kind of successful by the last half of 1970s. So in 1973, this is again the page from the North Carolina State Center for Health Statistics. The number of children born under midwife supervision had fallen to 1.6%. And just a couple of years ago, in 1930 or so, it had been about 20 or 30%. So it's a very steep decline by 1973. And the infant mortality rate has dropped to 21.7%, which, again, considering that it was much higher 20 or 30 years ago, is a good thing, objectively, that it's fallen. But what the state kind of takes away from this is that there was indeed an element of causation between midwives and the infant mortality rate. That because the rate of midwife supervision has fallen and the infant mortality rate has also fallen, there was a relationship here. And it's not that there necessarily wasn't a relationship, it's just that the relationship wasn't a one-to-one causation in the way it was sometimes characterized by these public health officials, right? Other super important things that are happening here are the provision of vaccines, are that more people, including women, are working outside the home, and so are more socioeconomically advantaged to actually be able to access proper nutrition or medicine that they might need. Transportation is better. And so if you live in a very rural area, it's no longer impossible for you to get to a hospital if your child comes down with the flu or pneumonia before they're a year old. So there are these other things that are affecting the infant mortality rate. But at this point, the midwife problem had been so pervasive in the early 20th century, and this effort at regulation had been so pervasive as well in accordance with that, that these two were kind of implicitly and sometimes explicitly linked. And so this kind of concurrent drop, even though they're not necessarily they're not necessarily related in a one-to-one fashion, are kind of viewed in that way. And so the state board and other public health officials are able to say, okay, the lay midwives are gone and the infant mortality rate has dropped. But if we kind of return back to today, this is a graph from 2013. In 1983, so 10 years after Mungo conducts her interviews, North Carolina passes a certified nurse midwifery law, which essentially allows nurses who have trained as midwives to practice. And up until a couple of years ago, they also had to practice under the physician or the supervision of a physician. And even despite that there is a population of midwives who are kind of incredibly educated in the way that some public health officials really wanted, the infant mortality rate in North Carolina and kind of in places like North Carolina across the South is still not where it should be if midwives had been the actual cause of the infant mortality rate. I don't have the current statistics, but I have here kind of the number of practicing nurse midwives, and you can see it's not a lot. And North Carolina is actually a maternal care desert, where there are lots of places across the state where there just are not sufficient supplies or resources for pre or anti or postnatal care. And so if midwives had actually been kind of the issue that they were regarded as during this time, what we would expect to see is a much lower infant mortality rate and for kind of maternal care across the state to be much better. But that's not the case. And so kind of I think, conclusion of my thesis is that this kind of idea that these statistics were objectively, or rather that they were objectively interpreted, and that objective interpretation meant that midwives were the cause of the infant mortality rate and getting rid of midwives would improve the infant mortality rate, isn't necessarily true. And that was wrapped up in the fact that part of the reason that there was a midwife problem is because physicians were newly entering the field of obstetrics. And so midwives had a range of patients who doctors were now interested in treating. And that was part of the issue. Part of the issue is a lot of these midwives were Black women who were kind of categorically regarded as untrainable or deficient by these public health officials. And part of it is also that their patients were also regarded in that same way. Many of these patients were Black women, and many of them were poor white women. And kind of across the board, the state was like, well, it makes sense to kind of focus on this one issue and not these other kind of more systemic issues that might actually improve the lives of these women and the outcomes of their children. And so I think looking forward, what's important to recognize is that midwives still exist in many areas of the state, especially certified nurse midwives, and they exist across the country. And many of them are still fighting to kind of return to an area where they can practice in accordance with what they know. So as I mentioned, until recently, they had to practice under the supervision of a physician, even though a lot of these midwives have substantial training and are licensed as nurses as well. So I think looking forward, something to recognize is that midwives provide very important care in terms of actually delivering children, but also in terms of postnatal care. Midwives traditionally were there after the birth of children. They would take care of the household. They would provide support to other family members. And physicians, even though they stepped in the place of delivering children, didn't also take on that role. And so I think it's important to acknowledge that not only did midwives serve a very direct physical role in terms of delivering children, they also served kind of a larger spiritual role, both in the lives of their patients and in the lives of their communities at large. So as we kind of look to midwifery as a historical institution and as a current institution, I think it's important to keep in mind kind of how multifaceted it was and what we lost when it was regulated to death as it was. Thanks, everyone.
Well, Genesis, lots of good stuff in there. And one thing I want to start out the Q&A with is how you got interested in this topic.
Yeah, that's a great question. I think I really love babies, is actually the actual answer. And then I'm a history of science major, and I took a lecture on the history of reproductive health in America my sophomore year, and I think those two kind of combined to really result in this interest. And as I was kind of reading on the topic and kind of exploring and experimenting with it, I came across this kind of really large and rich history of lay midwifery that I feel like is really unknown today. So I think that's probably where my interest started.
Oh, good. And we did have an earlier question that the participant said you answered about why North Carolina, but that relates to a broader question of, do you see in your research that North Carolina is pretty much the same as the rest of the South? Is there anything a little bit different about North Carolina with that sort of Southern pattern of the midwife problem?
I would say among the South, I think North Carolina I think we're headed in the right direction. I think there are a lot of representatives kind of in this legislature right now who are aware of this issue and who are working towards it. And I think there are definitely some Southern states or some other states that have higher infant mortality rates and were kind of more aggressive in terms of their midwife regulation. North Carolina had some of the first laws, but kind of in terms of how it actually manifested, I think there were states that were far more aggressive. And so in terms of that, North Carolina is actually certainly not in the worst position and certainly not, as bad as it could be.
So your point about North Carolina having some of the earliest laws, I think, is really interesting, because a lot of times we see interplay between federal and state. And of course, the Shepherd-Towner Act was just a year after that 1920 law that you showcased. So do you think that maybe what North Carolina was doing was kind of influencing the federal level, or what do you see in that interplay?
I think there was probably a lot of push and pull in terms of that. The Shepherd-Towner Act was kind of controversial when it was first presented, again, for reasons of kind of professional competition, where the American Medical Association was like very anti the idea of kind of equipping states to handle these public health issues in and of themselves. But the Board of Health had kind of been engaged and interacting with this issue beforehand. And like I mentioned, Rural Children, that kind of statistical document was kind of a collaboration between the federal government and the state government of North Carolina, where the Board of Health actually asked the Children's Bureau to come in and do that investigative work. So I think in general, there were a lot of factors influencing that. And I think there was probably a lot of kind of communal influence.
We have a question about when you'll present your thesis. You want to tell us a little bit about that process?
Yes. So I'm very fortunate to have gotten funding from Yale in part to come back to North Carolina and do research at the State Archives. And as part of that funding, I will present my thesis on April 16th. Yes.
I mean, fast. We had a comment from Renata about how 3 of her 4 grandchildren were born with midwives, one at home, which is cool. One of my children was born with a midwife in a birthing center, but it wasn't available in most of the places I had my other kids. So still some options out there, but it's in flux. And like you said, Genesis, it's a lot more standardized and medicalized and regulated, and the dictatorship of the clock in childbirth, I noticed, was the biggest difference between having a midwife directed birth and having doctor directed births. So that gets back to that holistic care that you were talking about earlier, and leads me to another question about the blame. And we had an audience question about those death certificates too, which I'll get to. But the blame, one of the examples you showed us was 3 months. You know, the baby was 3 months. So how are they blaming the midwife? Are they just expecting the midwife to provide that early natal care that, you know, today a pediatrician would?
Yeah, it kind of varied. And the thing is, obviously, like when a child dies at 3 months, that's clearly not an issue related to the delivery, or it's far less likely to be an issue related to the delivery. But when that certificate actually makes its way to the Bureau of Vital Statistics and gets translated into what happens in their report, that all of that context isn't present, right? That child just goes into the infant mortality rate, and it goes into it as kind of a child that had interacted with a midwife, and those numbers are kind of presented together in the final report. So there's a lot more that's happening kind of at the ground level, but when the state is actually making decisions and looking at its kind of full tabulations, a lot of that context has been wiped away, which is why, you know, you're able to make the conclusion, okay, the issue is the midwives, instead of saying there's another issue that's kind of being covered up here.
A lot of infant feeding can be attributed to, or many other things, diseases. So a few more personal questions about your process. We have some folks out there who are interested in getting in touch with you more about this topic. So if you'd like to share, we can send that out after, if you'd like to share your email contact. And then do you plan to continue this line of study in your graduate program?
Yes, ideally. I'm still not, I'm at that fun part of senior year where I'm not sure what I'm doing post-grad exactly. But if I do end up going to graduate school, it would be to continue studying midwifery.
Very cool. All right, so back to those death certificates. One of the names, it may not have been the 3-month-old. I think it was the second certificate you showed us, had the name Abraham Galloway. Can't remember the first one. And of course, that set off some bells with one of our participants, and me too. Abraham Galloway is a famous USCT leader, colored troops in the Civil War leader, and then becomes a state senator during Reconstruction. So just, I guess, wondering if you knew of any connection. However, I noticed it was Mount Airy. So that's, 60 years later and pretty far afield from where he lived in Brunswick and New Hanover counties.
It looks like the father's name was John Andrew Galloway, and then Johnny Ray Galloway was the name of the child in question. I wouldn't be surprised if there was some relation, but to the extent of my knowledge, I don't know anything. But yeah, I wouldn't be surprised if there was something.
Good little connections to fire off there. So is the list of registered midwives available at the state archives or online? Did any of those digitized public health reports have a list of names?
There's not necessarily a list of names, at least not from what I've seen. There are numbers about the amount. So there's like statistical information about how many midwives are practicing and where they're practicing. As far as individual names, I'm not sure if they kept track of that or if that would be preserved. But I haven't run across it in my search, but I'd be interested to see it as well.
It may be more at the county level. Have you checked county
Yes, I wouldn't
records
be
yet?
surprised. Yes, that's a good point. Yes, I I still have some thesis work to do. Yeah, so
I
that's
mean,
something
of
I
course,
might
we
look
have
at.
different
Sure.
counties, so that would be, you'd have to sort of pick select carefully counties to look at. Like I was interested in the Robeson County example, the newspaper, where it showed American Indian midwives being in the group with white for the training, and then later in the afternoon they had Black midwives. So
Yes.
Robeson would be a good case just to kind of show those dynamics. We have
Mhm.
another question from one of my colleagues about, just if you could give us your thoughts about your experience conducting research into public records, the archives.
It was, I think, especially interacting with other seniors at Yale now who are also doing research, I'm very, very lucky that the State Archives exists and has such a comprehensive selection. Um, Internet Archive as well had a lot of these digitized records of the State Board of Health reports. I have a friend whose research is on like musical traditions in 12th century England, and so obviously a lot of her sources are not digitized. So I think that's one of the things I really got to appreciate is how accessible these things are, especially considering I'm in Connecticut for most of the year. And so, having to kind of plan around when I would go home and actually be able to write by looking at resources, having digitized access to things was essential. So it was really great.
All right. I have another question that I pulled out a little quote from one of your slides, and it was from 1915, and it said, "A new policy of less begging, less postage, and more prompt resort to the courts." So I was thinking perhaps court records, or you and I talked about a court case in Caswell County might be a place to look, if you don't have to end in a month, but you're continuing much later. Have you come across
Yes,
anything like that?
I saw actually one, it was very early on, um, where slightly different, but they had brought a midwife to court and accused her of using medicines or things that were reserved for doctors. And so she was being accused of actually practicing medicine was the charge, which I thought was very interesting, how they delineated between practicing midwifery and practicing medicine. Because if you notice in the laws, they actually, a lot of them have carve out specifically for physicians. And she eventually, I think, was found not guilty, but there are a lot of interesting cases about midwives specifically and how they entangled with doctors and trying to kind of keep those lines separate.
So we do have someone in the chat who says she's a descendant of the midwife that we're talking about, I think, in Caswell County, and she'd like to say something. I don't know. Let's see. I'm not sure if I can allow speaking. I'll try. I'm not seeing where to do that. Oh, here we go. Okay, DR, you can speak.
Hi, can you hear me?
Yes, we can hear you.
Wonderful, wonderful. Genesis, congratulations on all of your work.
Thank
Definitely, definitely impressive and well needed, in particular during this time. I am so proud of you and just really, really encouraged to see the work that you're doing. And Adrian, thank you so much just for giving room and space for a presentation like this. I am Victoria. I am actually the fifth generation descendant of Henrietta Jeffries, who is the midwife that you are now speaking of, who was indeed brought up on charges of practicing medicine without a license in Caswell County, North Carolina. What I think is so crucial that is included in these presentations and in our thought processes as we begin to really, really unpack the impact of historical racism and, more importantly, the impact of resilience is that these midwives in particular were seen as a threat to the medical establishment. But nothing, nothing, nothing in that realm was a threat to the community. They were literally some of the most trusted health practitioners in the community and therefore were highly supported, highly regarded, and highly beloved by the community, as was the case of my ancestor. What makes Henrietta Jeffries so unique, even amongst her peers of midwives, was that when she went to court and was charged with practicing medicine without a license, she had already delivered approximately 400 babies, both Black and white. And this, I think, is how we know that she was so beloved. Not only was she delivering Black babies, but she was delivering white babies too. The white mom said, "Hey, wait a minute, we want to live and we want our children to live. We're coming to you. We trust you. We love you. We want you to deliver our children." So the local white physician conspired with the local white prosecutor in Caswell County to bring Henrietta up on these charges. As the court records note, when Henrietta went to court, the judge asked her on the charge of practicing medicine without a license, "How do you plead?" And she simply said, "Judge, if you mean that I helped these women when they needed me the most, yes, I'm guilty." My mom and I, when we were researching this and when we read the court records, we were a bit in awe. We were saying, wait a minute. Here is Henrietta Jeffries, an entrepreneur, a beloved midwife. She has 13 children of her own and a loving husband. Why would she put her own life on the line? Why would she say, "Yes, I'm guilty"? And then, of course, the jury brought back a guilty verdict as well. And the judge said, "Who's your lawyer? You're definitely going to need one." But to her credit, she said, "Judge, I have no lawyer but you and the good Lord." So the judge, to his credit, asked everyone in the courtroom to stand who had been delivered by Henrietta Jeffries. And don't you know that the entire courtroom stood up? So at that point, the judge then stood up, unzipped his robe, came down, and stood beside Henrietta and said, "On the charge of practicing medicine without a license, I find you not guilty." The entire courtroom erupted in applause because such a feat had never been accomplished by a Black woman in the rural South. So, this particular act of loving resistance is one that I think we see not just in my own family, but in families all over the South, where you have culturally competent, culturally sensitive, and moreover, loving women who are literally saying, "Hey, we are serving our own communities. And we know how to do that best because we are dearly a part of these communities." So again, Genesis, thank you so much for your work, and Adrian for providing a space for conversations like this to really come to light. And I think we can all learn from examples of midwives like this who love their community so much that they dare to put their own life and lay their own life down for such a cause as the future of our children. Genesis, I'm going to put my information in the chat. If I can be of help to you in your future studies, certainly let me know. I am a public health practitioner by training. And so this indeed is my life's work to follow my ancestor in her footsteps. So certainly looking forward to being of help.
Yes,
That's
thank you
great,
so much.
Victoria. We might have a midwife part 2, maybe next year. So we'd love to have your contact information as a presenter. It sounds like you're
Yes,
ready.
oh, it would be my pleasure. I'll put it in the chat now.
Okay, thanks. Genesis, I think we have some people logging off, but because it's past 1, but if you want to have any final words, you can take a moment, and we just appreciate so much you being here and sharing your work with us. And we look forward to more because you're
Yeah.
just embarking on this academic journey and lots more records to dig into with us.
Definitely, yes. Thank you, everyone, so much for getting in touch with me. I guess, Adrian, you'll share my contact information. And if anyone is curious to read my thesis when it's finished, it's kind of what I've talked about, but 40 pages more in depth. Yeah, let me know.
Right. All right, everybody. Thank you for being with us today. And Victoria's putting her contact information in the chat. And we will follow up with email. So thank you. All right, I've got that. I'm going to log off. Thanks, everybody.